Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
What is up, Wild Health gang? This is Erin Faules, and I have with me the esteemed Dr. Mike Stone, one of my good buddies, another doc at Wild Health. You guys have heard him numerous times on this podcast, and we are going to talk to you guys today about some common blocks to the Healthspan. This is the first of three of a series I'm going to do where we break down 7 of what we would consider the most common blocks to our health span, or basically living well and functioning for a long time, not just living for a long time. So today we're going to talk about atrophy, inflammation, and cancer, and kind of break down some ways that we can detect if this is going on, detect it early, and what we can do to intervene, and maybe throw some cool tech or kind of newer research in on things that maybe you have or have not heard of. So, Mike, anything else to add up front?
Oh man, I'm just so excited to hang out with you, Erin. It's been a long time. I was first of all, I'm just so grateful to you for taking the reins of the Wild Health podcast. That was my I was in that slot for about a year, and it is a labor of love. And you're doing amazing. And no, just excited to come back on in the guest role. So cool.
Yes, I love it. You and I have been on many a podcast together previously, and I'm pretty sure many a podcast on inflammation. So if anybody is really excited to hear Dr. Mark Stone and I talk about inflammation, I think there are probably 3 or 4 episodes on this where we dive much more granularly into that topic. So anyway, we'll get rolling. Let's start with atrophy. So we're going to kind of ease you guys in. We were talking about the order of operations here, and atrophy is something that maybe isn't talked about quite as much. I think more so in recent years with kind of the buzz with increasing protein and increasing strength training. But it's so fundamentally important, and it's not as frequently, in my experience, thought about when it comes to, the things that can kind of get us in terms of mortality or functionality of health throughout life. But it's just critically important. So when we talk about atrophy, we're talking about a loss of muscle mass primarily, or something called sarcopenia, or a loss of strength. However, it could be loss of brain tissue, loss of connective tissue. It can be other things, but I think primarily what we're thinking of and what a lot of the studies show us is going to be, muscle mass or loss of strength and that sarcopenia. Is that kind of what you think of when you think of atrophy, Stone?
Yeah, I mean, atrophy to me, because of my traditional, like, allopathic medical training, atrophy just means like shrinking of a tissue or wasting away of a tissue. And to your point, you can have brain atrophy, you can have other cellular atrophy. When I think of it in this context as sort of an essential ingredient to aging well, I really think of muscle and bone in sort of the same category of, are we losing muscle mass? Are we losing bone mineral density? And, the muscle mass trajectory, if we're losing it, which, by the way, if you're not working to keep it or gain it, you're losing it consistently from the time you're in your 30s. That's a big area to focus on. And then similarly with bone mineral density, if you're not working to maintain bone mineral density, you're looking at osteopenia, osteoporosis, increased fracture risk, frail bones. On the muscular side, why do we care? It's not to look great in a Speedo, but not that anybody would turn down looking great in a Speedo, but it's really, can you get up off the ground without assistance when you're in your 70s, 80s, 90s? Can you carry groceries yourself? Can you pick up and swing around the grandkids or great grandkids? So that's why it's those are the main reasons why it's important, and then there's like a trillion trickle down reasons, right? Like, muscle is our greatest metabolic organ. So are you going to have better insulin sensitivity and glucose management if you have more muscle mass? Yes, you're going to have that. So I kind of throw like muscle mass, flexibility, balance, bone mineral density, all in this category of body composition, which even though it's not one of the pillars of health, it should be an extra pillar is body comp.
Yeah, these all affect one another, right? I mean, muscle is also like potently anti-inflammatory, which is going to be the next thing we talk about, right? So it's really like the more muscle you have, the better able you are to burn fat, which is potently inflammatory and keeps you from getting your insulin levels driven down. So it's all like this circular, it's all related, it's all a domino effect, right? Um, you know, I think there's a lot of super strong I don't think there is a lot of super strong data on muscle mass and strength as predictors of living a longer, healthier life. I don't know the exact numbers, we can look them up, but I know there's a significantly like increased mortality risk with muscle loss just across the board. That's been studied numerous times. You're better able to survive cancer treatments when you have it's one of the biggest predictors of surviving a cancer diagnosis is having a good muscle mass when you go into it, as an example. So this is kind of clear in the evidence. I'm pretty sure grit strength is a better predictor of mortality than most cardiovascular metrics that you can look at as an example. But like then take it on the human level, we all probably know somebody that has had a major like a broken hip is a classic example, right? Like a major musculoskeletal insult, later in life that then just changed the trajectory of the rest of that individual's life, right? It is the beginning of a sequence of events, that just completely obliterate the health span, right? So that's just kind of, I think, a relatable one for people. Um, just to kind of put it in context for everybody. So, how do we detect this and what do we do about it, basically? So, just so we're not all gloom and doom on how bad it is when you lose it. Um, we really, really frequently use DEXA scans for body composition and bone density. They're frequently ordered for bone density in the traditional medical culture, but you can do really accurate body composition assessments, or you can get similar tests like an in-body scan or something kind of super quick and easy on your own, which is going to give a variation of this, maybe not quite as accurate. But you're going to have these are very, very accessible, very, very like budget friendly ways to have a huge like prediction of your long-term health and things to act upon. If you find your visceral fat mass or fat mass in general is higher than you like, or your muscle mass is lower than you like, then you can do X intervention and then retest and see did it work, right? So that's probably my favorite test for screening in terms of like muscle and bone density that we can get. So,
Yeah, I mean,
we
not a whole lot to add there except maybe, if you go and get, your traditional, primary care physician or internist to write you for a DEXA, they might be writing you for a bone-only DEXA, so making sure that if folks are gonna listen and go back to their own, providers around this to order a body composition study, which will give you less of a detailed look at bone density. It gives you sort of legs, spine, ribs, but when you're getting a bone-specific DEXA, it's looking at the femoral neck, the top of the thigh bones for hip fracture risk. It's looking at the lumbar spine with a lot more detail. So what you sacrifice in detail on the bone mineral side, with the body composition DEXA, you get visceral fat, right? That really inflammatory fat around your organs internally. You get appendicular lean mass, which gives you a sense of how well muscled you are. And appendicular lean mass index sounds scary for people, but all it really is your muscle in your arms and legs, the weight of that muscle divided by your height squared. So it's just a normalizing function to say how well muscled you are, even if you're 5'2" versus 6'1". And then, um, DEXAs, you don't need to repeat them super often. Every 6 to 12 months would be plenty, even a little bit longer if the body composition takes time to change. But I find this to be one of the most high value things that I get in terms of an assessment of someone's body composition, you really have targets to start with, you have a baseline to start from, and there's really very little else that makes people as happy as looking at their DEXA 9 months later and saying, "Wow, I lost 6 pounds of fat and a pound of visceral fat, and I gained 2 pounds of muscle." It's a great thing to be able to actually do in a data-driven way. Not that I mind, like, are your clothes fitting better? Do you feel better? All of that's great too in the interim. But it's a nice evidence-based way of following how you're doing on a body composition program.
Yeah, for sure, for sure. Um, cool. And then say you get a DEXA back and lean mass is lower than you'd want to see, muscle mass is lower than you'd want to see, or you're just like looking to optimize that to begin with. Like, what are your favorite, obvious or maybe not so obvious interventions, Mike?
Yeah, I mean, definitely straight to gene therapy, right? It's like,
Obviously.
obviously like a myostatin inhibitor or no, follistatin gene therapy. No, the this is something that we chat about all the time, internally and with the people we take care of. Living a really long and healthy life, and particularly healthy, it's not always as sexy as the newest supplement and the newest peptide and the newest, gene therapy and medication. Not that there aren't roles for different, more advanced, elements to healthcare. I mean, this is the most exciting time ever to be in medicine. But at the end of the day, 90+% of your progress is gonna come back to fundamental, tried and true things that we know work. And they tend to be lifestyle based, which is why health coaching is such a huge part of people's journey is how do you take this advice and I'd say like phase one is you go see your doctor and they say eat less, move more. That's not helpful, and usually not accurate anyway. um then phase two is okay, we want you to hit this protein goal, we want you to lift weights or have this element of your resistance training, and we'll see you back here. And that's also better, but not helpful, right? You need to actually have a structured program that works for people with their lifestyle, with their goals, with their abilities, with their prior injuries, etc. So it's all more nuanced and personalized than whatever we're going to talk about here. But um, resistance training, right? Actually, strength training. And that can be in the form of kettlebells and dumbbells, barbells. It could be in the form of some of the EMS suits that can actually stimulate the muscles directly. It could be in the form of rucking, right? And actually just like putting some weight on your back and working out. There are like micro weight vests that can add to the resistance when you're doing more cardio activities. If what you like is to really play pickleball or tennis, then add some weight and keep doing the things that you love. I mean, I think leisure sport is probably the most underestimated lever to pull for so many people to improve their overall fitness. But at the end of the day, what do you need to grow muscle? Is like there was my long preamble, Aaron. What do you need to grow muscle? You need to stimulate the muscle, resistance training, some sort of weighted exercise. Body weight stuff will also work, but not as strong of a stimulus. You need to eat an appropriate and minimal amount to meet the criteria so your body can perform muscle protein synthesis. So you need adequate dietary protein, and you need to sleep. And if you're lifting heavy weight in whatever form that is for you, you're eating enough protein and you're sleeping, you're going to put on muscle mass. And there are some blockers, right? And some adjuncts. So, like, blockers would be maybe you've got a hormonal imbalance. And if you're, let's say, a male in their 60s and your free and total testosterone is low, you might not see the same gains that you would if your testosterone was more physiologic, right? We're not going to turn this talk into a testosterone talk, I promise. Different topic, different day. Similarly, women's hormonal health needs to be optimized, or women aren't going to gain lean muscle mass the same way. Um, are people overtraining? Are they not giving their muscles enough time to recuperate? That's a big blocker to gaining muscle mass. And are they doing, like, way too much cardio? You can ending up in an accidental caloric deficit from all the cardio activities. It's why you see those bodybuilders with, like, the cardio kills gains T-shirts. Not
Totally. Or
not
you're just upregulating your cortisol so much that you're just blocking sex hormone formation and you can't. build muscle effectively. You can't use any of your hormones. That's something I see
Yeah.
so often in women, especially in the perimenopausal time, but really throughout women's lives in childbearing years as well. Like, women are so much more sensitive to environmental stressors and physiologic stressors. And, women are often kind of not what I call polarizing their exercise enough. They're doing a lot of the like mid cardiac zone burn, boot camp style or long form cardio that is just kind of not really checking the box for longevity in terms of cardiorespiratory or muscle building that much, honestly. But the effort is amazing. And it's super unintentional and they're working so hard and not really meeting any of the goals. So if you like lift slower and heavier, much heavier than oftentimes people are lifting when they come to us, and then a bit more intentional about the type of cardio for other health benefits, it can just you can see massive results. And often, like you said, that's paired with other limitations in lifestyle for women. Oftentimes I see underfueling, sometimes for men too, for sure, but I see it a ton in women, underfueling for actual muscle gains, specifically with protein and carbs, or the type of carbs. So anyway, we could go down this rabbit hole. We work on this a ton. Our health coaches work on this a ton. It's super fun stuff. The Catalyst suits or the other brands as well, EMS suits are kind of interesting. I like a couple of the points you brought up. Those are super interesting. I mean, I feel like they're kind of I hear about them a lot from like super busy executives, and it's like, you're fitting this into a short period of time for your day, and it's like very regimented, but they're super interesting to use for like post-injury recovery or times when like functionality is limited in terms of actually getting under a lot of tension for the muscles. And I think there could be like a cool application to later in life or like post-injury rehab, or I don't know, I just get curious about this. So the EMS suits are kind of interesting. And then I also really like the idea of like monitoring your recovery, like you said. Like, if you're not sleeping, if you can't actually repair that muscle. So, monitoring, like, are you adequately recovering? Are you recovering as hard or harder than you train? Are you able to actually, like, build muscle? Because you're putting all these amino acids in, and then you're building the muscle and breaking it down and, like, getting time under tension with the strength training. But are you actually if you're not seeing results, then, it might be as simple as that. So, anyway, cool
Yeah.
stuff. Oh,
And
and
just oh, sorry, go ahead, Erin.
well, I was gonna say I like your weighted vest idea too. I feel like that's like the gateway to strength training for so many of my patients because I'm like, "What do you do for activity?" And they're like, "I walk," and I'm like, "That's amazing. Maybe add 10 pounds to that," and it's like such a cool entry into that. And then like a year later, it's a whole different conversation, but it's like meet yourself where you are, like you're saying, and just add a bit of weight there. So I love that you said that.
Yeah, I mean, it really does need to there's a few things that just pop up there, and then we'll maybe close the door on atrophy and move on. But the, one is, injury prevention and recovery, whether it's, EMS suit or it's training with BFR bands or it's going all the way up to like a Vasper where you're doing like cooled BFR band workouts. I mean, there's so many things on the market now to help with recovery, or with training through an injury, I should say. Um, and then the other thing that comes up is just that lots of effort, little results that you were referencing around like the boot camp stuff and the moderate intensity. Like there's nothing more heartbreaking, on a body comp scale for me when somebody's doing something so hard and working so hard, and there's just a missing element. And that element might be dietary protein or underfueling. That element might be, hormonal imbalance or stress, just cortisol
Mhm.
management. And they're really working so hard and not seeing gains. And almost always, if you just make a couple of simple tweaks and often slow people down, take away a workout day, give them more time for intentional structured recovery, then you see these folks just have these massive improvements. And for the CrossFit crew, I think, I can't count how many people I had them go 1 or 2 days less a week to CrossFit, and it was like a 3 to 6 month battle to get them to believe that, and then immediately started really improving, and their times got better, and their PRs got better, and, it's just, it's
Totally.
about
Or
finding that balance.
or like have a snack before your workout, and then maybe you're not pre-diabetic 3 months later. So, it is super, super cool when you track this data and make kinda both with your internal biologic data, whether it's from a tracker or just a gut check, honestly, oftentimes can do the trick. And then kind of follow some of these labs, like Stone is saying, some simple tweaks can just be, like, massive for, like, long-term ROI. Okay, I just thought of something because I feel like this is such a buzz topic right now, and you're kind of our in-house expert on this, so I'm gonna ping you on this. But the body composition, right? Keeping muscle mass up. Patients usually when they say I want to lose weight, they mean I want to lose fat, I want to tone up, right? Um, I know at Wild Health, as a general rule, we have a little bit of a different take on GLP-1 receptor agonists than maybe some other clinics or groups of professionals do. It's kind of a polarizing topic out there. I don't think we really view it in that way. But what would your thoughts be on when it comes to body composition? And we'll probably circle back on this because it affects some of the other categories as well. But what are your thoughts on how you manage this when it comes to GLP-1s for body composition goals? And are you doing DEXA scans while you do it? Like, just are you worried about patients losing muscle on these? Like, how do you approach this?
Yeah, I mean, way to not throw in a controversial topic there, Erin.
Sorry,
Um,
controversy is so fun on podcasts.
I don't mind it, as you well know. Yeah, I mean, I think I'll for the sake of not going down a giant GLP-1 rabbit hole,
Yeah,
and for
elevator
listeners who aren't,
elevator pitch it for us,
yeah,
Mike.
for listeners who aren't familiar, GLP-1s, we're talking about things like semaglutide, tirzepatide, retatrutide, like a bunch of the brand names you've seen the commercials for and heard the songs.
Oh,
Um,
oh, oh,
the
Ozempic.
yeah, that thank you for corrupting that my love of that song. The the simplest way I can put this is that I think that, those medications, GLP-1 medications can be tremendously useful for a number of aspects of our health, from body composition work to, anti-inflammation to cardiovascular risk reduction, and obviously metabolic health and, control of prediabetes and diabetes. I think they, should be viewed the same way that everything else that we talk about should be viewed, which is in the context of multiple other interconnected factors. If you are taking a large dose of a GLP-1 and you're living a sedentary lifestyle and not changing your diet, you're very likely to lose some fat and some muscle and to have the potential for a worse overall body fat composition, and body fat percentage. Um, if you're using it at an appropriate minimal effective dose, you're prioritizing protein intake, sleep, resistance training, and you're tracking results, I think they can be a huge value add. So it's just like almost anything, water can be incredibly healthy for you, and you can drink too much of it and develop low sodium levels and have seizures, right? And you can drink too little of it and get dehydrated and have kidney failure. I don't think everyone needs to be on a GLP-1, like everyone needs water, but I think when done responsibly as part of a comprehensive plan, tracking to make sure that you're detecting muscle loss, and even better, planning to avoid and prevent muscle loss. I've seen people put muscle on GLP-1s and lose fat. I think it's completely achievable, but I think it requires more than like a telehealth prescription for a medication and no other real changes to your lifestyle. So I can't say that I'm super disappointed that people can't just like hop on Hims and order a GLP-1. I think that
Yeah.
it needs to be done responsibly, and it's not something to take lightly. And I think, evaluating along the way, measuring, determining how people are responding. These medications have side effects. It's not something to enter into lightly, but at the same time, I think they can be a huge value add when done responsibly.
Yeah, totally. Like, we talked about this at a meeting earlier today, internally, but it's just such a good reminder. There's no free lunch, right? Like, none of these things can be these hacks are super cool. And like, we have patients that are coming to us that are they're checking all the boxes. They're doing so many things. So sometimes adding some of these quote unquote hacks can make a lot of sense. But even still, like you're not gonna have to not do the work. Like whether it's a GLP-1 or something else, they're useful as a tool in addition to, these other lifestyle things. So, and like Mike said, like managing and tracking metrics while you're doing these is super helpful. And, sometimes the doses of these are a tenth or less than what you may have heard of. That is super, super effective, and all that might be necessary for your body. So kind of interesting. Cool. Let's talk about inflammaging, whatever you want to call it. A topic you and I have talked about many times before. So, kind of to get to basics, I think most people have heard of chronic inflammation. Inflammation is not all bad whenever, you have it in the acute setting in response to an injury, an illness, a burn, a fill in the blank. Our immune system is there for a reason. It does its job. It should go away and not be turned on all the time inappropriately. It should help keep us safe, and kind of that's that. Um Oftentimes in tons of people there is a bit of that or a lot of that going on, chronically activated, and that can cause a lot of damage over time. So a lot of things we look at Wild Health and just in the general health space can track this in terms of detection. And then this is one of those topics that's like there's so much overplay into, or interplay rather, into, our metabolic health, our blood sugar, how much muscle mass we have, increased inflammation raises cancer risk. Like these are all connected, right? So this is not like an isolated subject. But when it comes to inflammation specifically, good old fashioned blood work is kind of the name of the game. And I would probably add to that probably methylation testing and genetics are actually also very, very helpful here, in terms of kind of the ROI of like where to put your efforts for someone. But, there's a ton of blood tests. HSCRP is kind of, or high sensitivity C-reactive protein is probably the gold standard still. Is there anything else in terms of detection for systemic inflammation other than symptomology? I would say also that is, super helpful here.
Yeah, I mean, I don't think an erythrocyte sedimentation rate adds a whole lot to a CRP, ESR. I know there's some, and I've never asked you if this is like on your radar of things you like to throw in there. I mean, from the rheumatologic side, there's some folks who feel like it adds some value on top of CRP. Um, I don't do a lot of like cytokine testing. If you're looking at like TNF alpha, IL-1, IL-6, they're expensive. They don't tend to really help me much. If they're elevated, it's because their CRP was elevated or their symptoms were consistent with chronic inflammation.
Right.
I mean, we look at homocysteine, we look at metabolism, we look at lipids. I mean, when I look at chronic inflammation, I take, yes, we do all that testing, but it's really like, what are the key drivers and where does someone potentially fit in? And that can be anything from like obesity with, visceral, abdominal fat, insulin resistance, and dyslipidemia. Like those are, high lipids. Those are pro-inflammatory on their own, and those are, obesity, prediabetes, insulin resistance, diabetes, and dyslipidemia. Kind of common in our American population. So those are always like easy targets.
Mhm.
Um, Nutrition. Right, so ultra-processed foods, food sensitivities like gluten, dairy, those can be big drivers. Generally, like, low fiber, low phytonutrient, low antioxidant diets, um, not having any omega-3s in their life, alcohol intake, right? These are all key drivers. You mentioned and, testing, the one other thing I might throw in there is microbiome testing,
Yeah.
both like gut and dental, those chronic periodontal disease, H. pylori, gut dysbiosis, those are all key drivers. And then like environmental, we didn't really touch on, whether it's like, air pollutants, heavy metals, forever chemicals, mold exposures. I mean, I think that those are all,
Yes.
potential sources of chronic
Functional
inflammation.
medicine rabbit hole.
Yeah, the rabbit hole of functional
It's
medicine, and then,
real.
it's
It's
real, yeah.
real. And also, I like to put an asterisk by this because I trained in functional medicine, and these things are real and they deserve like legitimate testing in certain scenarios. And I believe it is over tested in a lot of people, because I believe there's a percentage of resilience that should be there, right? Like there's a capacity to like respond appropriately to these environmental factors. However, if you're like in a mold infested home and have chronic massive exposure, it doesn't matter how resilient your system is. It's a problem, right? Like
Yeah.
in any number of these things can be an excess, whether it's a certain type of virus or infection that you're chronically exposed to, whether it's heavy metal exposure that's massive. More often than not, what we're seeing is a combination of these things. Like someone has an inappropriate exposure, and then someone has probably an inherent genetic risk to inappropriately respond to that exposure. And it's probably compounded by years of stress, maybe some other chronic inflammation, maybe some methylation dysfunction, like this perfect storm that allowed this, like, kind of like not that scary of insult, not that extreme of an insult to really creep in and like wreak havoc. And so you're still left with typically not that different of a plan, at the end of the day, if that makes sense. Like,
It
oftentimes
totally does.
when people
Yeah.
ask me about like, should I do mold health testing? Should I do mold testing? Should I do this? Should I do that? Like sometimes the answer is yes. But usually I'm like, well, are you worried about mold exposure in your home? Like, why don't you start there? Why don't you do some environmental testing? If you have a massive like positive, then yeah, we need to look at a before and after on a mycotox, and we need to do some like protocols here. Or more often than not, I'm like asking the question, like, why is your system maybe not responding appropriately to these things? And how can we support the balance there to where your system is more resilient? So it just kind of begs a deeper question for me, oftentimes with these folks' immune systems. I love what you said about the gut health and the dental. I think those are two of the three most common buckets I see really impact inflammation. Dental's like the least common in frequency, but like the most sensitive. If somebody is like
Yeah.
has a stubborn CRP and I'm like, where is this coming from? Like, and I'm like, have you gotten like, is there anything going on in your mouth? Like, do you have a Tuesday? Do you have like something like actually, So this is like such a sensitive deal. And there's lots of evidence on links to dental health and inflammation and heart disease and mortality. And that's a kind of
Dementia.
its yeah, for sure, kind of its own bucket. Gut health is super common, super sensitive and super common, I would say, in our patients. And then I would say the other bucket that's like much less concrete is chronic stress, history of trauma, autonomic dysfunction or nervous system, dysregulation, leading to like this loop where our immune system is chronically dysregulated and activated in inappropriate ways and suppressed in inappropriate ways.
Yeah.
So that's
100%. Poor sleep quality, chronic sleep deprivation, chronic
yeah.
psychological stress, just like, dysregulated
Yeah,
sympathetic nervous
emotional or
system.
physiologic stress, right?
Yep.
Like,
Yeah, and that could be, yeah, it could be overtraining on one side, and on the other side, it could be like, an elevated adverse childhood experiences score, right? It could be stress, and we have epigenetic data looking at aging that, people who have high ACE scores, from, childhood trauma are biologically aging faster, right? This is part of the mind-body link that for, ever, Western medicine has kind of trivialized or ignored because it's not something that can be as easily studied, and yet we see this
totally.
time and again, that just re-regulating and reprogramming the nervous system to get people to actually tap into a parasympathetic balance, just across the board tends to, we see, prediabetes normalize, we see sleep
Mhm.
normalize, CRP normalize. I think the only other thing I think I'd throw in um, on the docket here is a sleep study. I've
Yeah.
seen several people with chronically elevated CRPs, and it turns out that they have undiagnosed obstructive sleep apnea, which is one of the most that's like the definition of obstructive
Yeah,
sleep
good call
apnea is
out.
it's undiagnosed, underdiagnosed. And nowadays with home sleep studies, $150 later, you can have a diagnosis instead of the fear of going into a lab and trying to sleep in some scary place with a million electrodes
Mhm.
attached to you. Like, this is very, very accessible these days.
Yeah, totally. And another call out I would say about inflammation is most typical laboratory panels you're going to get are going to say a C-reactive protein under 3 is just fine. And I think we would both disagree with that. You aren't going to have as dramatic increased risk of sudden cardiac death with a C-reactive protein under 3, but like let's raise the bar from that for our standard of living and goals, right? So to fill your best to reduce risk of pretty much every chronic disease on the planet, we want to keep it under 1 for sure, if at all possible. So anyway, lifestyle for the vast majority of this, depending on what's driving your inflammation, is going to depend on what our plan is here. Obviously, we're going to treat, insulin resistance driving inflammation or high lipids driving inflammation or cholesterol different than we're going to treat a history of PTSD driving inflammation, in which case we'll just tell you to stress less. I'm just kidding. There's like lots of lots of super I joke about this because I do our autoimmune consults and I have a history of autoimmunity myself. So this is like a near and dear topic to my heart, all joking aside. And I think like pretty much most people just get told to stress less, and myself included when I was in the midst of my diagnosis. And it's like the most infuriating thing, right? Because like we all
Yeah.
would if we could.
Yeah,
Um,
it's one step worse than to eat less, move more.
right.
Right. Yeah, sure. Just
Um,
stress less. Yeah,
yeah,
I mean, there's so much that, talk about like the most exciting time to be alive in medicine. I mean, between stellate ganglion blocks and EMDR and CBT and DBT and psychedelic therapy. And I mean, there's just a million tools out there to actually take the stress less advice and turn it into actionable evidence based approaches that, when done with qualified people, yield amazing results. I mean,
totally.
these are, but I think that's a great, I love the way you framed that, if you're having a high CRP because your triglycerides are 350, it's a lot different plan than if you're having a high CRP because you're recovering from, chronic psychosocial stress, or you're overtraining, or you've got gut dysbiosis, right? And while all these things are connected, that's some of the most fun of what I feel like we get to do with folks, is really take the time to dive in. And, a nod to functional medicine here, actually, like, a really good interview and really understanding multiple facets of
Yeah, for
someone's
sure.
life, we're able to kind of focus there.
For sure. For sure. Cool. All right. Third topic. Thank you for maybe the 2 people who are still hanging in here with us. Just kidding.
We got
Um,
you. We'll keep this one shorter, we promise. This one's this
um,
one's this one's pretty straightforward.
yeah. So, this is kind of a more commonly talked about, blot square health span, cancer diagnosis. Name of the game here is, prevent with, the things we've already talked about, quite frankly, today: metabolic health, inflammation, muscle mass, etc. Like, let's give our bodies a chance to not develop cancer. But early detection is kind of where tech is helping us here. And so that's kind of, I mean, I won't go so far as to say it should take the place of standard screenings. I don't think we're there yet in terms of cancer screenings. So we're all still recommending, your age appropriate cancer screenings, colonoscopies, breast cancers, whatever your age appropriate screenings are. So this is not to take the place of any of that. However, there's some cool stuff going on in terms of early detection that we're using pretty regularly. I don't want to speak for you, Mike. I'm using pretty regularly in practice. I don't know about you.
Yeah, I mean, I think, the standard kind of US preventative task force guidelines around colonoscopy, cervical cancer screening, mammography, et cetera, PSA, and free percentage PSA testing for men. I mean, I think these are all super important, shouldn't go away. And I think the devil's in the details, honestly, for things like full body MRI, or, cancer DNA fragment blood-based biopsy testing. And when I say the devil's in the details, somebody might be tempted to say, "Oh, I don't need to get a PSA done because I had my blood-based cancer screening done." The blood-based cancer screens have about 11-12% sensitivity for prostate cancer. They perform very differently for certain types of cancers than for
Mhm.
others. The one other sort of preventative thing that I think is underutilized out there that I would throw in is lung CT for former smokers.
Mhm.
So lung CT is often not thought of, and there's actually a really interesting article. I think it was JAMA last month on lung cancer screening in non-smokers in populations in which non-smoking lung cancer types are more common. So
Mm.
really interesting. We might see more of that coming
And this
our
should get
way
approved
as
for
well.
ever smokers, right? Like, "Oh, yeah, I smoked for, like,
Yeah,
a
it's
month in
forever.
college." Yeah, yeah.
Yeah, yeah. And then, when I say the devil's in the details, like partially it's about, well, is this better and should it replace any of the other standardized testing? I think the answer to that's a very resounding no. The detailed devilness is really you're going to find on full body MRI, you're going to find some incidental findings. I've never seen a normal full body MRI. Everyone has, not everyone, most people have either cysts in their kidneys, cysts in their liver, maybe a cyst in their pancreas. They'll have some abnormal variant of their blood vasculature in their brain. They'll have
I've seen numerous
degenerate.
brain cysts on these.
Yeah, you see brain cysts, you see thyroid abnormalities that are often not cancerous that lead to a bunch of downstream testing. You can see a ton of cervical and lumbar spine degenerative disc disease and osteophyte complexes. So, you need to know going in that there are almost guaranteed going to be some abnormalities. And just to have, like, is that something that raises your cortisol and stresses you
Yeah.
out and puts you in a place where you don't want to have the testing done? I think my beef, if I have one, is places that are just straight up ordering and nobody really knows that that's gonna happen, that they're gonna have abnormal testing. So
Mhm.
that's something I talk to my own people about before we do that test. And then similarly, the blood-based cancer screening has the same issue. Now the good news is that even though cancer is poised to take the place of coronary artery disease as the number one killer of men and women in the US and worldwide in the next several years, the overall incidence at any given time of cancer is quite low. And as a result, if you do one of these tests on a population of several hundred people, you might get all no cancer signal detected results, and everybody's high fiving and super happy that they don't have any cancer signal. When you do get a positive test, about 6 out of 10 of those positives are false positives, meaning that the test shows up positive as concerning for cancer, but there actually isn't any cancer there. And I think the downstream testing from that, people need to know upfront. So if you have a positive cancer screen on one of these blood-based biopsies or blood-based cancer screens, you will get a full body CT, a PET scan typically, to look for cancer. And then if that doesn't show a source, then you're going to have repeat blood-based cancer screens done monthly for the next 3 to 6 months. So talk about increasing stress. If you were to have a positive that was a false positive, which again, 60% chance that your positive is a false positive, you're really lining yourself up for several months of freaking out about where this cancer is and can it be detected, et cetera. Now, the balance of that is the 4 out of 10 who have a true positive are very likely to detect cancer at an earlier stage,
Mhm.
and early detection is key to survival rates. So, it's not that I'm trying to, play the curmudgeon and say this has no role in our approach. I order a lot of these tests, but I think that sort of sit down conversation about what the test means and what the results mean. I have
Mhm.
had people say, "No, thank you. I'm cool. I'm gonna do the lifestyle stuff that I know will decrease my risk of cancer. I'll go ahead and do the preventative screenings. I might even go ahead and do the MRI, because I'm comfortable with something I can look at and see, but I don't wanna do a test where 60% of the positives are false positives." And I think it's just, having a shared decision-making model around whether or not to do that test is, is really important. I mean, we are as a population in the US, I think it's the same drive. I'm on a soapbox here. I'm gonna stay on for 60 more seconds. I think the same driver of, "I'm gonna take a GLP-1 and that's gonna fix my health." And that's all I need to do. That same sort of like same day delivery mentality of I can get everything on Amazon Prime right now. I can watch anything whenever I want to. I should just be able to order something and fix my health. That same mentality, I think, applies in in this screening sense, right? Like we get over tested and under transformed, right? Like I have a million tests back. That's great. And that's going to somehow give me the agency to make the changes I need to make when most of the changes are lifestyle based. So all that said, I think these are amazing tools when used responsibly, when used in coordination with what a patient's goals are, and to make sure that people are informed about the kind of tests that they're getting. I mean, the same way that you go in for a surgery, they have to tell you the risks of the surgery, not just the benefit of the surgery. I think we need to do a better job as a community of providers who are trying to practice really cutting edge healthcare to inform our clients and our patients of what the testing means, what a positive would do, what a negative or normal would do, and sort of what to anticipate, and then have some good shared decision making about whether that's something that slots into their healthcare goals.
Yeah, this is like the name of the game with how we practice, I think, and I think it's like such a beautiful thing that we can have pretty much unlimited communication with our patients. Like I directly message all of my patients, which is not something I'm able to do. I mean, I have a medically complex kiddo and I hired a concierge pediatrician for him just to be able to do this. Even though I'm a doctor, I just didn't want to wear that hat, right? And like, it's super common that you call your doctor and you just like get a call back in 3 days by the whoever at the office. And, this ability for us to communicate with our patients and take all of this really sexy tech and, diagnostic tool kit that we have at our fingertips and we'll have more and more of now with AI. And how do we bring it, like bridge it with the human of like, what's your risk tolerance, right? Like what are the things, like what's your budget? What are you comfortable with testing? Like what are you comfortable with knowing? I mean, I know me personally, I haven't gotten the Gallery test. I haven't gotten the cell-free DNA cancer testing because I'm not comfortable with that 60% false positive yet. And for me, that's not a super high risk that I know of in my, genetics and family history. There's certain other tests that we have that I think are absolutely incredible. And I just consider my job as a doctor just a translator, honestly. Like I'm going to translate what this is. And then you decide what's your risk tolerance, what are your goals and how can I help you achieve those? So I love that we're able to do that for our patients. I also think we can use the data that we have access to now to help patients make those decisions, especially when it comes to genetics. And this will get more and more accurate soon, I think, with AI. But looking at like where are the areas that your system is most at risk, where might it make sense to do some of this deeper, more granular diving? So we're not just testing all the time and spending all your money and taking all your time and freaking you out and whatever else it may be. But where can we look at like what are the actual high ROI areas for your system? Where are you more susceptible to disease or to mortality? And where can we help like optimize and strengthen those? And I think we can use some of this like information and these diagnostic tools to help guide us there and determine which of these tests make the most sense. So anyway, I love that we do what we do and we can get the foundational data first to look at the person as a whole, like what are the lab work and the genetics show, like what is this patient susceptible to, and then bridge that with the actual human being and determine like, okay, that top like 5% of data of the extra testing, like what actually makes sense for this individual after all of that is talked about.
Yeah. I mean, to your point, right? The root of the word doctor is, in Latin, "docere" is teacher. It's to teach. It's not to tell somebody what to do. So that translator role, I think, all you're doing is teaching. You're translating complex, specialized knowledge into a language that someone without that training can understand. And if we can just do that and listen more, it's like the best job in the world.
Yeah. Cool. Well, excited to continue this series. We've got some more coming for you guys down the line. We've got heart disease, we've got metabolic dysfunction, we've got mental health, and we've got one more that I'm total neurodegenerative dementia. So some other fun, maybe not fun, but some more like important topics to break down with some of our other docs. Thank you so much, Dr. Stone, for joining me.
Oh,
It's
so
been a
fun, Erin.
pleasure
Thanks
as
for having me.
always. And y'all stay tuned for more.
Sounds good.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.